Hello everyone, myself Yogita, a second MBBS student. Today I am here to give a seminar on chronic pyelonephritis, renal cell carcinoma, and hydatidiform mole gross and microscopic features. First, let's look on to chronic pyelonephritis. The chronic inflammation of tubules and interstitium that causes scarring of calces and pelvis of the kidney is known as chronic pyelonephritis. There are mainly two types of chronic pyelonephritis, that is reflux nephropathy and chronic obstructive pyelonephritis. Nephropathy is very common in children due to infection superimposed on vesico-ureteric infections, and chronic obstructive pyelonephritis, which is precipitated by the obstruction causing repeated bouts of inflammation. On looking to gross features, kidneys are usually small and contracted, showing unequal reduction. We can see here this is the common normal kidney, and this is the kidney which has underwent chronic pyelonephritis. We can see this is contracted and there is unequal reduction in this kidney. The surface of the kidney is irregularly scarred. We can see the scarring of the surface of the kidney here. The capsule can be stripped off due to adherence to the scars also. These scars are of variable size and show characteristic U-shaped depression on the cortical surfaces. There is blunting and dilatation of calyces and a dilated pelvis of the kidney. We can see there is a dilatation here. So this is the gross features of the chronic pyelonephritis. Now looking on to the microscopic features, first let's see the interstitium part. The chronic interstitial inflammatory reactions, chiefly composed of lymphocytes, plasma cells, and macrophages, with pronounced interstitial fibrosis. That is, there is a fibrosis in the interstitial part. A special form, that is xanthogranulomatous pyelonephritis, is an uncommon variant characterized by foamy macrophages admixed with other inflammatory cells and giant cells. Tubules, they show varying degree of atrophy and dilatation. Dilated tubules may contain eosinophilic colloid cast, producing thyroidization of the tubules. That is, in the tubules they get contracted. That is, they are atrophized, and there is colloid formation inside the tubules. They give like a thyroid appearance. And on looking to blood vessels, in the scarred areas, they show obliterative endarteries, and hyaline arteriosclerosis can also be seen. That is, the blood vessels undergo hyalinization, and glomeruli, often periglomerular fibrosis is seen. In advanced cases, there may be hyalinization of the glomeruli. That is, the glomeruli undergo hyalinization, and there is deposition of fibroblasts around the glomeruli. See about renal cell carcinoma. Renal cell carcinoma are the tumors that arise from the epithelium of renal tubules. They constitute more than 90% of the malignancies that occur in the kidney in both the sexes. The tumor is twice as common as in men than in the women, and usually present in the 6th and 7th decades of the life. These tumors may arise in any portion of the kidney but occur predominantly in the poles, especially in the upper pole. On looking onto the risk factors of the RCCs, the risk factors associated with RCC are as follows. Those are tobacco chewing, this is the most significant risk factor, obesity, hypertension, estrogen exposure, ESRDs, petroleum products and heavy metals exposure, and tuberous sclerosis. Now let's see about the classification of the renal cell carcinoma. There are mainly 5 types of renal cell carcinoma. First, let's look on to clear cell carcinoma. Clear cell RCCs are the most common type of renal cell carcinoma, accounting for up to 70 to 80% of the cases. They arise from proximal tubular epithelium of the nephrons. This is the most commonly and the most important type of the renal cell carcinoma. Now, looking on to the papillary carcinoma. Papillary carcinomas account for up to 10 to 15% of the cases. These may be familial or sporadic types. Now, on looking on to chromophobe carcinoma, these carcinomas account for up to 5% of the cases of RCCs and are associated with multiple chromosome losses. These arise from intercalated cells of collecting ducts and have an excellent prognosis. Now, looking on to multilocular cystic renal neoplasm, these neoplasms are multicystic, low grade variant of renal cell RCCs, presenting in the middle aged men more than in females. They have minimal risk of reoccurrence and metastasis. Looking on to the last type, that is collecting duct carcinoma. Collecting duct is also known as Bellini duct. This is a rare variant with an incidence of less than 1% of the cases of RCCs. It arises from the collecting ducts in the medulla. Now, first look on to the features of clear cell carcinoma. Now, let's see the gross. Gross features are they are solitary, unilateral lesions. You can see they are solitary and unilateral lesions. Variable in size, and they are found out bulging out, distorting on the renal surface, but are well defined and confined within the renal capsule. The cut surface appearing yellow gray and variegated in appearance with hemorrhage and necrosis. You can see this is the cut surface and the yellow appearance with a little of hemorrhagic and necrosis appearance. Now, looking onto the microscopy, lesions are composed of solid, trabecular, and tubular patterns with interspaced, delicate branching blood vessels. That is, they are giving chicken wire blood vessels appearance. Cells are round with clear or granular cytoplasm filled with glycogen and lipids. The cells appear clear because they are filled with glycogen and lipids. This is why this is known as clear cell carcinoma. Lesions have unique pattern of spread. They may invade renal vein, this extending to the inferior vena cava and right up to the right side of the heart. On immunohistochemistry, these tumors show positivity for carbonic anhydrase 9 and CD10. Here we can see there are a lot of clear cells. This is due to the glycogen and lipid deposition in the cells of the kidney, and this invades to the renal vein and to the inferior vena cava and right up to the heart. Now, looking on to papillary carcinoma, the gross features are this is named papillary carcinoma because of the papillary architecture it has. They are often multifocal and bilateral and arise from the distal convoluted tubule. The cut surface of the tumor is hemorrhagic and cystic. Here we can see the hemorrhagic appearance of the cut surface of the kidney. Looking onto the microscopic feature, microscopy shows papillary growth composed of a core containing interstitial foam cells and lined by the cuboidal to columnar cells. They may be lined either cuboidal or columnar cells. Stroma is scanty and vascularized. Presence of samoma bodies is another notable feature of this variant. Immunohistochemistry, the tumors show positivity for cytokeratin 7 and alpha methyl acyl CoA racemase. Here we can see the papillary appearance of the renal cells. This is either lined by columnar or cuboidal cells. The stroma is scanty and it is also vascular. The presence of samoma bodies, this is the notable feature of this variant. Now, looking on to chromophobe RCCs, the tumor composed of cells with prominent cell membrane, eosinophilic cytoplasm with the wrinkled nucleus and perinuclear halo arranged as sheets around the blood vessels. This is the feature of the chromophobe RCCs. On immunohistochemistry, tumors show positivity for CKIT and CD117. Here we can see the chromophobe RCC. Now looking on to multilocular cystic renal neoplasm, the gross, it shows unilateral and composed of cysts of varying sizes filled with clear serous or gelatinous fluid and no mural nodules. That is, the cyst may be filled with the clear fluid or serous or gelatinous fluid. Here we can see the cyst with the fluid accumulation in it. This is the typical feature of the multilocular cystic renal neoplasm. And on microscopy, neoplasm shows cysts with septa composed of groups of clear cells similar to cells of. Now, looking onto the microscopy of the multilocular cystic renal neoplasm, the neoplasm shows cysts with septa composed of groups of clear cells similar to cells of clear cell carcinoma. This is the microscopic feature of multilocular cystic renal neoplasm. Here we can see the septa and the cells are clear here also. Now looking on to the last, that is the collecting duct carcinoma. This is also known as Bellini carcinoma because the collecting duct is known as Bellini duct. The tumor is located in the medullary region. The malignant cells show hobnailing and are arranged in glands in fibrotic stroma. Hobnailing is a feature of this carcinoma. Here we can see the collecting duct carcinoma. Now looking on to the last topic, that is hydatidiform mole. The word hydatidiform means drop of water and a mole for a shapeless mass. This hydatidiform mole is defined as an abnormal placenta characterized by two features. One, that is enlarged edematous and hydraulic change of the chronic villi which become vesicular, and the second one is variable amount of circumferential trophoblastic proliferation. Now looking on to the classification of hydatidiform mole. Hydatidiform mole can be mainly classified as invasive and non-invasive. Non-invasive can be further classified as complete mole and partial mole. Invasive mole, it invades the myometrium by atypically proliferating trophoblasts, leading to penetration or perforation of the uterine wall, and this is why it's called as invasive mole. Now, first looking onto the complete mole, the gross features are the uterus is enlarged and is filled with grape-like vesicle up to 3 cm in the diameter. The vesicles contain clearly watery fluid. Rarely, a macerated fetus may be also present. Here we can see the grape-like appearance in the uterus. These vesicles are watery filled. Here we can see the watery filled nature of the vesicles. Now looking onto the microscopic features, the features are quite typical here. They are large round edematous and acellular villi due to hydraulic degeneration forming central cisterns. There is decreased vascularity of villus stroma. Trophoblastic proliferation in the form of masses and sheets of both cytotrophoblast and syncytiotrophoblasts, generally circumferential around the villi. Here we can see a round edematous acellular villi. This is due to hydraulic degeneration forming central cisterns, and there is decreased vascularity of villus stroma. Also, we can here we can notice that is there is not lot of blood vessels here. Usually in the placenta there are a lot of blood vessels, that is fetal blood vessels and the maternal blood vessels. Now looking on to the partial mole, the gross features are It doesn't cause any enlargement of the uterus as a complete mole. That is, in the complete mole, the uterus is usually enlarged, but in the partial mole, it is not enlarged. A partially developed fetus with multiple malformation is present. That is, in the uterus, fetus is present, which is usually malformed. And in the microscopy, some of the villi show edematous changes while others are normal or even fibrotic. Trophoblastic proliferation is usually slight and focal. Here we can see the edematous changes in the villi, while others are bit normal, but others even undergo fibrotic changes. The trophoblast proliferation is usually slight and focal here. Now looking on to the invasive mole, the gross feature is it shows invasion of the molar tissue into the uterine wall, which may be a source of hemorrhage. In the invasive mole, the typical feature is the bleeding. That is because the invasion of molar tissue into the uterine wall causes hemorrhage here. Rarely, molar tissue may invade the blood vessels and reach the lungs. Then, on looking onto the microscopy, bin, uh, it's a benign lesion and identical to classical mole, but has potential for hemorrhage. The classic clinical feature here is the hemorrhages here. Here we can see the invasive nature of the hydatiform mole here.